Hi there, my name is Greg Kaufman. I'm a medical resident at the Mayo Clinic in Rochester, Minnesota. I'm here at the ASH meeting. We're presenting the results of our study entitled Adverse Cytogenetics with or without Trisomies in patients undergoing high-dose therapy for multiple myeloma and the impact of post-transplant maintenance therapy. So maintenance therapy in multiple myeloma remains controversial. In the last several years, there's been a few major publications looking at the use of novel agents as maintenance approaches. There's controversy whether these prolong overall survival for patients. Our study wanted to look at specific subgroups of patients with specific cytogenetic abnormalities to determine if there was a difference in progression-free or overall survival with the use of transplantation and maintenance strategies in the novel agent era. So for our study, we retrospectively looked at all patients who we treated at Mayo Clinic who underwent high-dose therapy, which means a stem cell transplant for initial therapy for multiple myeloma within 12 months of their diagnosis. And we only included patients who we had good data on what cytogenetic abnormalities they had. And we specifically looked at adverse risk markers such as 414, 1416, 17p-, with or without concomitant trisomies on myeloma FISH panels. So in terms of what we found overall, we had 300 patients who, after their transplant, had some sort of, were evaluated for maintenance therapy. Of those 300 patients, 73 of them had adverse risk cytogenetics at diagnosis. We further then looked to compare a group of patients who had adverse risk cytogenetics with or without a concomitant trisomy, which is an extra chromosome found on one of the tests the myeloma FISH panel performed at diagnosis. What we found was that there was a significant difference in progression-free survival with the use of maintenance strategies, either bortezomib or lenalidomide, after high-dose therapy and autologous stem cell transplantation for the group of adverse risk patients who had a concomitant trisomy, as compared to those patients with adverse risk markers who did not have a concomitant trisomy. However, there was no difference between the two groups looking at overall survival. The term of our follow-up, or the limit of our follow-up, was approximately 40 months was the median. So in conclusion, we found that for patients who have adverse risk FISH markers and a concomitant trisomy, maintenance strategies with either lenalidomide or bortezomib significantly improve progression-free survival as compared to those patients with adverse risk FISH markers who don't have a concomitant trisomy. And these are interesting findings, and we think that these should be looked at in future prospective trials of maintenance therapy for multiple myeloma patients.